Okay, hello everyone. Thank you for coming today to the Neurons Matter seminar series. And it is our pleasure today to have Seoyoung Lee. She's a PhD student at the University of Oslo in the field of neuroscience and pain. Before pursuing her master's degree, she worked briefly as a Korean medical doctor in a pain clinic. During this period, she gained interest in non-specific effects in pain relief interventions. She started her master's studies based on these interests, studying the analgesic effects of open-label placebos and the unique pleasant pain experienced during massage and acupuncture sessions, very in line with our interests of the network. Currently, she is working on implementing pain reprocessing therapy for chronic widespread pain patients at the Oslo University Hospital in the Department of Radiology and Nuclear Medicine. And we are very much looking forward to her talk today about her work. Thank you, Seuyoung, and please go ahead and take it away.
Thank you for the great introduction. I have this pop-up screen. Let me just get rid of it before I start. Okay. Hello, my name is Seoyoung Lee, and this paper I'm presenting today is a research during my master's study in Korea, supervised by Yoon Byung-chae and In-sun Lee. This is a picture here of my previous school, Gyeonggi University, and this research was done in my previous lab, Cognitive Medical Science Lab at Gyeonggi University, where I wanted to study the phenomenon of people enjoying painful massage. Before I start, I want to say that it is very amazing for me to talk in front of people, researchers who are more expertise in the field of massage. And even if I don't know the field as much as the many researchers in this room, I would be very happy to share my research and also get some nice inputs from you. So first, I was interested in the phenomenon of pleasant pain. According to the International Association for the Study of Pain, pain is defined as an unpleasant feeling in your body and emotions. It is usually connected to an actual or possible damage to your body. So in the definition, it starts with the word unpleasant. But if we talk about something different, pleasant pain, it kind of sounds strange. However, we could often experience that people feel good even when they're experiencing pain. For example, when you're getting a massage that is quite painful, some people can actually enjoy massage that is painful, and they also feel pleasure along with the pain. Previous research using MRI imaging have shown that there was a shift in brain activity during pleasant pain when the pain was given in the context of relatively alleviating context. Individuals even showed pleasure in the same moderate pain when the pain was given after a stronger pain. This response, reduction in activity in pain-related areas of the brain, and the activation in reward areas, indicating a neural mechanisms for this phenomenon, was termed hedonic pain by the author Cyril. So while pain is typically viewed as an unpleasant sensation, the concept of pleasant pain highlights the complex interplay between pain perception and, paradoxically, pleasant and pleasureness. So while investigating the phenomenon of pleasant pain, I focused on myofascial trigger points because this is an area where a lot of people do massage and a lot of people have pain in their body. So myofascial pain syndrome is a condition that is characterized by pain and autonomic symptoms caused by the activation of trigger points in the muscles. Trigger points are hypersensitive spots within the top band of a skeletal muscle, causing pain when pressure is applied to the area. When it comes to trigger points, they have some characteristics such as having a low pain pressure threshold, meaning it gets painful easily. And also they often exhibit high muscle stiffness, contributing to a stiffness feeling and discomfort. One common treatment for myofascial pain syndrome is ischemic compression therapy, which involves deep pressure and similar to massage. This involves applying gradual pressure to trigger points until the pain threshold is reached. Previous studies have shown that this therapy can lead to several positive effects, including a decreased subjective pain experienced by the patient, and also increased pain threshold, which indicates a reduction in sensitivity to pressure, and also improved joint mobility and increased blood flow in the affected area. Interestingly, in a previous research, participants have reported experiencing pleasure with deep pressure, similar to the sensation of C-tactile touch. Brain activation patterns during deep pressure resembles those associated with pleasurable touch, and researchers here suggested that the emotional effects of deep pressure may vary depending on the social context. So here I wanted to briefly introduce some previous studies on massage and their results. One study was on human touch massage. Researchers conducted a study using touch massage, which involved a force of 2.5 newtons, which is slightly lighter than deep pressure, and with a velocity of 1.5 centimeters per second. They examined 4 conditions: with or without movement and with or without a rubber glove. And within these 4 conditions, interestingly, they found that human touch that was combined with a movement was most pleasant for the participants. And this combination also significantly activated a specific brain region called the pregenual ACC. This area is also known to activate during other pleasant sensations and is also involved in the effects of opioid analgesics and placebo. Another study focused on moderate pressure massage, which stimulates pressure receptors under the skin. This type of massage have been found to enhance vagal activity, leading to a reduction in cortisol level and an increase in immune functions. Consistently, vagal activity increased after this moderate pressure massage, and there is a possibility that the limbic system, including the hypothalamic structures, could be involved in this cortisol secretion. I brought another brief PET study where participants in a prone position received moderate pressure massage, and researchers observed that the cerebral blood flow increased in several brain regions, which was involved also in depression and stress regulation. These regions included the amygdala and the hypothalamus. This suggests that moderate pressure massage may engage the brain's mechanisms for managing stress and mood regulation. Specifically, it involves hypothalamic regulation of autonomic nervous system activity, cortisol secretion, and limbic activity associated with the emotional regulation. Lastly, I wanted to introduce a FNIR study using massage and trigger point, which is very similar to my study. Here, researchers compared 2 groups while giving deep pressure compression into trigger points or the non-trigger points. they maintained the compression intensity to a level of visual analog scale 4. And the researchers here found that the participants in the trigger point group reported a significantly low subjective pain compared to those in the non-trigger point group. And also, these changes were correlated with decreased concentration of oxygenated hemoglobin in the dorsal medial prefrontal cortex in the trigger point group compared to the non-trigger points. And these changes were also correlated to improvements in heart rate variabilities and subjective pain levels. So from these previous research, I wanted to see, I wanted to investigate the phenomenon of pleasant pain in trigger points and non-trigger points. So the research hypothesis was that the trigger points would be associated with pleasurable sensations of pain because these areas are often chosen for massage treatment or acupuncture treatment, and more likely people are likely to seek pressure voluntarily in this area, as if you may have experience, if you have shoulder pain, you tend to press the region of the trigger point to relieve your pain voluntarily. Also, we expected greater pleasantness and relief when deep pressure was applied to the trigger point compared to the control. Our research objectives were to compare the differences in muscle tension and stiffness between the trigger points and control within the same muscle, and to compare the pressure level until the pain is felt. We also aimed to observe subjective ratings after applying deep pressure to trigger points and control. So the study method is as following. First, we measured the baseline characteristics of the participants, BMI, whether they had massage experience, and if they have a preference to massage. And then these healthy participants were brought to a Korean medicine doctor who selected the trigger point and control within the muscle of brachioradialis. The trigger point was selected in an area with a taut bed and a hypersensitive spot within the brachioradialis muscle. Several potential trigger points were identified through palpation, and then the Korean medicine doctor compressed the area to check hypersensitivity. On the other hand, to select the control site within a 2-centimeter radius of the selected trigger point, the Korean medicine doctor found an area where there is no hypersensitivity to pain and where there is no existing taut band. Next, we used a device called Myotone Pro and a pain algometer to measure the muscle properties, the muscle tone and muscle stiffness, and also to measure the pain pressure threshold at both the trigger points and control. The machine to the left is the Myotone Pro, which measures the muscle tone and stiffness, and the algometer is shown in the right. After measuring these properties, another experimental researcher came and applied deep compression to all participants, and all the participants received deep compression on both areas of TP and control. Pressure was administered through the assessor's thumb until the participant felt moderate pain, and when they felt moderate pain, they were instructed to ring a bell that was on the other hand. After ringing a bell indicating moderate pain, the pressure was maintained 12 seconds, and we used the digital pressure sensor system to monitor the maintenance of the same pressure. Lastly, we asked participants to report how they felt during deep compression, and at this point, pain, pleasantness, unpleasantness, and relief was rated through a 0 to 10 visual analog scale. So this is another picture illustrating what I just explained, how we identified the trigger point and control in the muscle of brachioradialis, and we, in order to counterbalance the order and to blind the researcher giving massage, we marked the trigger point and control with a O or X marker. However, the researcher wasn't informed which one was the TP and which one was the control. So after the experiment, this is a picture of all the data collected of the pressure scale, and we could see that pressure was given gradually increasing, and after hitting a moderate pain level, it was maintained for 12 seconds. So for the results, here are the baseline characteristics. We had 48 participants, which were 26 of them were female and 22 of them were male. The study was conducted in a university, so most participants were university students and their age was 22.5. All participants had a normal BMI and a normal body fat level. Among the 48 participants, 95.8% of the participants had experienced a massage before. So first, for the results of the properties of the trigger points and control points, measured with the Myotone Pro, you could see the trigger point, which is pictured in blue, and the control, which is colored in gray. Participants had a higher muscle tone and higher muscle stiffness in the trigger point compared to the control point, while the pain pressure threshold, the trigger point had a significantly lower PPT than control, thus meaning that participant felt pain in a much lower pressure than the control. Next are the results of the psychophysical responses to deep compression at the TP and the control point. Here, as I told you before, we measured 4 ratings of pain, unpleasantness, pleasantness, and relief. And here, participants had no significant difference between trigger point and control. We aimed to, this was our aim because we asked them to ring the button when they felt the moderate pain. And you could see that there wasn't a significant difference between pain in trigger point and control. Next, in this non-different pain situation, participants felt a significantly lower unpleasantness when deep compression was conducted in the trigger point compared to the control point. However, there was no significant differences between TP and control in the pleasantness rating, except for a small effect size of Cohen's-d 0.2, with trigger point being slightly higher pleasant than control. Lastly, we measured the relief, and we could see that trigger point was significantly higher than the control, with average 3.6 out of 10 compared to 3.1 in control group. After we gave these ratings and after the deep compression, we asked participants which point, TP or control, produced the sensation that was more preferable to them during the deep compression. And out of 48 participants, 32 participants preferred the trigger point more than the control. And this was tested through a chi-square goodness of fitness, and we found a significant difference between the preference of trigger points and non-trigger points. So for the discussion, our main results were that properties of TP and control was different. For muscle properties, we found a higher muscle tone and muscle stiffness in the trigger point group compared to the control group. This is because the trigger point is located in a taut band within a muscle, and stiffness and feeling a hard sensation below our skin is a property we use when identifying trigger points. Another finding was we found lower pressure pain threshold at trigger point compared to control, which shows that trigger points exhibit higher sensitivity to pain compared to control. Next, for our results, comparing the subjective responses after deep compression, we found no significant difference of pain between trigger points and control. So participants both felt a similar level of pain during the deep compression itself. However, participants reported a lower unpleasantness and a higher feeling of relief during trigger points, despite they perceived similar amount of pain. Also, after the deep compression, when we asked participants whether which point they preferred more during deep compression, more participants preferred deep compression on trigger points compared to control. Unique results were that although the trigger points were preferred and they rated less unpleasant than control, the pleasantness level was not significantly different. We expected a higher pleasantness with relation to the therapeutic context. However, we think that in this study, participants were not in pain, and they were healthy participants. And in a experimental setting, it was more difficult for the participants to feel a therapeutic context, which would have affected perceived pleasantness. Also, the pleasantness rating itself was very low, so we also thought that there would have been a floor effect. So we think that further studies should consider conducting trials in more relaxing settings. Our study investigated the relationship between pain and pleasure experienced by our participants when we gave deep compressions to trigger points and control areas. And in a review paper on massage therapy, deep pressure has been shown to evoke positive emotions such as pleasure, with the brain activity similar to tactile touch. And previous MRI experiments using mechanical pressure application of a study by Laura Case I read while building up the study, when they applied pressure to the foot area using a machine, it showed similar positive emotions and brain activations to tactile touch with deep pressure. Also, in experiments applying ischemic compressions to trigger points and control areas, deep pressure at trigger points resulted a shift in heart rate variability. In a way, it increased parasympathetic activity and decreasing sympathetic activity compared to control areas. And these were also correlated to the significant decreases in the prefrontal hemodynamic changes, reflecting that the brain activation is also related to the vagal and autonomic nervous system during massage. While these previous studies have observed the emotional and physiological effects of deep pressure, the study was the first study to observe the emotional responses to deep pressure at trigger points and both control areas. Our results suggest that pain could be accompanied by pleasure depending on the context, with deep pressure at trigger points could be an example of the phenomenon of people feeling pleasure during massage or pain. So one of our challenges in our study was, it is also related to the challenges in any study using trigger point, was the difficulty to accurately locate the trigger point. In our study, we used latent trigger points. In myofascial trigger points, there's two types of myofascial trigger points. One is active trigger point, where the trigger point itself produces pain, while latent trigger points produce pain when it is compressed or has manual examination. While symptoms in patients with latent trigger points are comparatively more mild, the latent trigger points also have the potential to become active trigger points and also the prevalence of latent trigger point is higher compared to active trigger points. So it is significant, clinically important to detect latent trigger points. And previous research on latent trigger points showed lower pain pressure threshold and higher muscle stiffness compared to surrounding normal muscles. So we choose latent trigger points for these reasons. And we wanted to accurately locate the trigger points and the control in our setting. So we had a Korean medicine doctor to determine based on palpation whether it is the trigger point and the control. And after the detection of these 2 points, we compared the properties using the Myotone Pro machine and measuring the PPT to further examine and to determine that the trigger points were consistent to previous research and that our trigger points were actually trigger points based on these properties. In a recent workshop of NIH HEAL initiative workshop of myofascial pain, they also stressed that the necessity of finding a way to detect trigger point is very needed, and we need interdisciplinary research to overcome these limitations. And here they suggested pain pressure threshold, ultrasound, electromyography, and myotonography. So although we couldn't implement all these techniques to ensure that we found the right trigger points, we did use the PPT and Myotone Pro to confirm our trigger points. So next, to think about the potential mechanisms behind this pleasant pain. For neurophysiological mechanisms, we think that in the introduction, I presented some previous studies, and we thought that some brain regions which integrate the sensory inputs and their emotional context and motivational meaning, including the orbital frontal cortex and anterior cingulate cortex, might be associated with the emotional processing during these painful and pleasant stimulations. And also, we thought that the effects of contact itself would be very important in pleasant pain. In a previous study using acupuncture, people were given pain in different contexts, while some people were receiving pain as a needle, while some people received the same stimulus, but they were explained that this was acupuncture treatment. And responses to pain differed when pain was induced in a therapeutic setting compared to a non-therapeutic or experimental setting. So we thought that the context would be important. However, in our experiment, it was difficult for participants to feel that this is a therapeutic treatment, as these people were healthy participants, and the setting was more like a laboratory instead of a calming treatment or massage therapist area. So some limitations of the study was that, like I just mentioned, this study was conducted in a laboratory setting, so it might not fully reflect the effects of deep pressure massage when it happens in the clinical environments. So it would be nice to have additional experiments in the clinical setting to further investigate the therapeutic effects, which would be combined in actual massage. Also, all participants were healthy young adults, so these results may not be generalized to patients with actual myofascial lesions and pain in the area. So it would be nice to conduct experiments on these effects to real pain patients. Finally, participants' responses to deep pressure were collected only in subjective reporting formats. So in future research analysis should focus more on factors that could affect deep pressure compression at trigger points, and using other rating systems such as the MRI. We actually had a follow-up MRI study after this experiment to observe the neurophysiological changes related to deep pressure compression at trigger points and control sites. We're still analyzing the data. However, the limitations I mentioned right now, difficulties of participants feeling a therapeutic effect in the laboratory settings were actually more worse in the MRI setting, because it was very difficult to maintain the pressure in a massage style in an MRI machine, and the machine itself is very stressful. So participants had a very low pleasantness and a high unpleasantness report compared to this study. So we're still looking at the data, but it would be more interesting to find a way to integrate massage studies in laboratory settings where we could reflect the actual clinical environment better than our study. So finally, the conclusion of this study is that even when similar stimulus of here, the pressure is applied within the same muscle, the emotional experience can vary, although they experienced similar levels of pain. Our study observed the characteristics of trigger points and control sites in the brachioradialis muscle. Muscle tension and stiffness at trigger points were higher compared to the control, and PPT was lower. And when this deep compression was applied, the discomfort was lower and the feeling of relief was greater at the trigger points compared to the control sites. So this is my research, and if anyone has any ideas or questions, please tell me. I wasn't able to read the tests because my mouse isn't working in the Zoom setting, but yeah, thank you for listening.
That's great. Thank you very much, Seuyoung. I'm sure there are going to be questions, and please either raise your hand or you can just jump in if you'd like to ask one.
Can I start?
Sounds good.
I wondered if you checked, well, thanks very much. It was very interesting. I wondered if you checked if there was a relationship between the pleasantness or unpleasant ratings and the relief ratings.
Oh,
You know,
yes.
if pleasantness or unpleasantness is related to relief.
Yes, we did a correlation analysis, and it was assumed, but people with high unpleasantness had a lower relief, and people with higher pain felt higher unpleasantness. So all the 4 subjective ratings were highly related to each other.
I have a couple of questions. This was so interesting. As you know, since I invited you, thank you. One question is, what were the participants told about what you were looking for? Were they told specifically that you were looking for trigger points? Were they aware of that language, or did you tell them when you found trigger points, or were you just moving from point to point, conducting pain testing, moving on, no other framing?
Sure. We wanted to blind the participants as much as possible. I didn't bring the results of blinding, but they were told that we are looking through pain in different regions of the body, and this was conducted with a series of other experiments that is about acupuncture points. So they just thought they were getting pain on acupuncture points. And for blinding, we just after the Korean medicine doctor found some potential trigger points, they tried their best to kind of hide which one was the trigger point by applying pressure to multiple points and just continuously asking pain levels. And another researcher was writing down the pain levels of each pressure. And then after these ratings and their palpitation, they just marked 2 points of the control and the trigger points with a O and X. Yet the participant wasn't told which one was trigger points, and they never, until the end of the experiment, they were never told about any of myofascial pain syndrome or trigger points.
Great, wonderful. Did you happen to collect any ratings of mood or anxiety at any point in the study?
No, we didn't. I guess for anxiety, no, I think if it was pain patients, it would have been very interesting data, but we didn't in this study.
Do you think participants felt anxious undergoing a lot of pain testing, or just it wasn't the maximally relaxing environment of massage?
Yeah, if there was a more therapeutic context, I guess measuring anxiety before and after the experiment could have been interesting to see, and if there was a difference, but overall, as these patients were healthy young adults, I don't think there would have been a big difference in anxiety level.
I'll be really curious what your MRI results yield. That's really cool that you followed up with MRI. And I mean, you said that the pleasantness ratings were even lower in MRI. So I just wonder, even if it's not clinical levels of anxiety, it's stress, right, from the MRI environment or the medical environment. I wonder if having the massage therapist or whoever's administering the massage, like, give an actual genuine massage before starting the study might increase trust and potential pleasantness. And the fact that that is necessary is obviously interesting in and of itself.
Actually, I think that would have been very helpful for if we knew before we started the MRI scannings, because we didn't measure anxiety, but we did we rated PANAS and some other questionnaires, and before and after the MRI, we could see that they were, in general, they were unhappy after the MRI scannings, regardless of what they received that day. So, and they didn't have any context of this treatment. So, I guess, like as you suggested, if we had a massage session before and some explanation about the therapeutic effects, it would have been actually helpful for the participants to understand the therapeutic context and results.
Yeah, which is so interesting how much that context matters. Thank you.
I have a quick question.
Hello. Oh, sorry.
Uh-oh. Sorry.
Go ahead.
Sorry, we had a little bit of feedback. Thank you for a great talk. I was wondering if you had considered using the algometer, the myotonometer, to kind of reassess the tissue after the deep compression. I was wondering if, for example, trigger points, maybe their stiffness changed more significantly than the healthy tissue, or if they kind of came back towards maybe a healthy tissue, a control tissue, more so, and if that was also then related to the amount of relief a participant felt.
We did measure, we did use the algometer before and after the deep compression. However, we thought that the data wasn't consistent enough to report, because after the massage, it was difficult to maintain the same position of the muscle, because a slight difference in the muscle, for the myotone and the muscle stiffness, it changed a lot. And for the PPT, since they received a lot of pain in general, regardless of the trigger point and control, I think both points were more sensitive after the compression.
Gotcha.
So
Okay. Thank you.
Hello, I had also some questions. I was wondering, because you said that all the participants had a normal BMI. If you asked if they did physical activity, and if there was any, if you did have that data, if there was any relationship with the pain, because doing physical activity, you usually do experience somewhat a bit of pain, right?
right, yeah. No, we just asked whether they had pain, but I think it would have been very relevant to the study, especially if do you exercise your arm, or if we measured or asked and listed what kind of pain they experienced and what kind of exercise they did, but we didn't for this study.
Okay, and maybe I missed it, but you asked about the social touch questionnaire. Did you find anything with that?
We asked the social touch questionnaire, but I don't think we found any results significant with the pleasantness ratings.
Okay. Okay. Well, nice talk. Thank you.
Thank you.
Would ask a question as well. When you're administering the deep pressure, it seems, and trying to obtain the pain pressure threshold, you have some kind of flexible sensor on the finger. Is that right?
Yes.
And you're pressing in, and the person keeps pressing sort of slowly and incrementally, and then eventually the receiver says, "Okay, stop." Is that right?
Yes.
And
Yeah, that's
and when they say stop, that person who's administering the pressure maintains that same level of pressure for 12 seconds after that.
yes. Yeah.
And that's the plot that we're looking at, I guess, that you have up here right now.
Yeah. So we first thought using the digital force gauge itself to maintain the same pressure, but we also thought that then it will really lose its aspects of being a massage. So we wanted to have the human touch as possible as we can, yet we also had to ensure that the pressure was maintained. So we used the very thin force sensor beneath the thumb, and to measure what you just explained, a 12-second maintenance in the pressure level.
Thank you. Okay, others, does anyone else have any question?
Sorry, really quick, the VAS4 that you calibrated to, so sorry, did all the points receive the same pressure level at the post-test, or they all received to the PPT level?
Which one?
Sorry,
which-
like when you were measuring the deep compression, pleasantness, and pain, what was the stimulus the same for every point? the pressure level, or was it individual to
The
that point?
pressure, yeah, no, the pressure level differed between TP and control. So whether the pressure was it was matched to a VAS4. So when they felt moderate, which was the pressure was lower in trigger points compared to the control. So they did receive different levels of pressure in 2 points.
I see. Okay.
I had one more question based on something I saw in the chat too. Going back to that figure where you have the 3 muscle tone, muscle stiffness, pain pressure threshold. Yep, that one. So does a line represent one participant?
Yes, this is parity test, and one line is the same participant.
And each participant, in the control and on the trigger point, is that one measurement, or is that a collection of measurements that are, averaged together?
Mm. It's just one measurement, yeah.
Okay. So you'd I don't know if this was asked or not, but I guess the question in the chat was if you repeated the test on each of those points, but it seems like you did it one time on each of those points.
Yeah.
And maybe that related to the answer you had earlier, that it's hard to, exactly relocate the position on the same position on the trigger point.
Yes, exactly. So this is not the whole data set. This is all the data before applying deep compression. So these are the baseline measurements, just comparing the properties of TPs and control. We also had the same measurements after the deep compression. However, we thought that it was difficult to maintain the same position after the massage. And for some participants, muscle tone and muscle stiffness was very different, more different than it should be after a massage. So we thought it would have been how they positioned after the massage.
Great, thank you. Okay, I'm doing a last call for questions. Anybody have a burning question that you need to get out of your system? Okay. Seuyoung, thank you very much. We really appreciate your discussing this work. And just for anyone out there, we're going to be posting this to YouTube later. So if you want to watch it again, you'll get an opportunity to do it then. Thank you all very much and have a great day.
Thank you for listening, and I hope I have a chance to talk more about massage and your findings in future meetings or future events. Thank you very much.
That's great, thank you.
That was great. Thank you.
Thank you.